Hi, Adult Health 2. This is chapter 40 of Endocrine. This is the first of 4 PowerPoints because there are 4 chapters. We do 40, 41, 42, and 43. Each chapter is only about 25 slides at the most, so nothing crazy. It's kind of nice to break them down like this. So chapter 40 is just pathophys and some assessment, okay? Here's our objectives. All right, so the endocrine system includes glands found in various locations in the body, works in conjunction with the nervous system. It's associated with metabolism, growth, development, glucose control, and sexual functioning. So the endocrine glands include hypothalamus, pituitary, the adrenals, thyroid, parathyroid, gonads, and there's some cells in the pancreas, the Langerhans cells, islet of Langerhans, or however you say it. So those are considered endocrine, and but it's just part of the pancreas. So the thing with the endocrine glands is they secrete hormones, and hormones are just chemical messengers, right? Hormones are telling another part of the body to go do something, to release something, to do something. So just chemical messengers, right? That result in physiological function. So it's just, like I said, chemical messenger just telling the body to do something. So when we are talking about these endocrine glands, you can have hyper or hypofunctioning, meaning the gland is making too much or too little of the hormone. Okay. So what's nice about this though is your hyper your hyper signs and symptoms that you see are going to be the opposite of what you see with hypo. You really only have to remember like one of each, like hyperthyroidism, because hypothyroidism is going to look the opposite of hyperthyroidism. So when you guys are studying this stuff, just keep that in mind. You don't have to overthink like, well, what is going on with this one and blah, 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 blah. Focus on one and then in your brain, flip it. Okay, because it's going to be the opposite. Hormones from the endocrine glands are secreted directly into the blood system. We compare this to exocrine glands, and those are like released through ducts. Okay, so that's the difference. The endocrine stuff goes directly into the blood system. Um, Let's see. The book does talk about like the primary disorder involves dysfunction of the endocrine gland. Then secondary is anterior pituitary. Then there's third and quaternary, right? You don't really have to memorize any of that stuff. Just know that the endocrine system is a cascade. Okay, and when it releases these hormones, it goes and tells a hormone beneath it what to do. And so it does depend on where the malfunction is with these hormones as to what ends up being affected the most, okay? Because different glands do different things, obviously, right? Um, I am looking through my notes here. Let's see. All right. So the notes are talking about the endocrine system being a negative feedback system, meaning that it takes a hormone getting low to stimulate the release of another hormone. Okay, so by negative, it's just referencing the fact that, hey, we're almost out of this hormone, you better go make some more. And so it'll stimulate production of this, which stimulates production of that, and then production of whatever is the low hormone. Okay, so when we are talking about those different hormones, we are looking at what stimulates what and what needs to be low, okay, for the next hormone to be stimulated. All right. So slide number 4 just identifies our endocrine glands for us. We have the hypothalamus, the pituitary, the adrenals, thyroid, parathyroid, gonads, and islet cells of the pancreas, islet of Langerhans. Okay. I actually remember learning about that in school. Slide number 5 is talking about um, patients who are on steroids for about 10 to 14 days, the importance of tapering steroids off because of the effects extra steroid, corticosteroid can have on like the hypothalamus, anterior pituitary, adrenal cortex, and the normal hormonal feedback system, right? Because cortisol is a hormone. And so if we have a person on steroids, we are um of course I can't think of the word, but artificially, there we go. We are artificially adding cortisone to the mix, right? The the hormone, the endocrine gland was not stimulated to make more cortisoid. We just gave the body more cortisoid. So that can throw things off because again, this is a negative feedback system. So the body is going to interpret that steroid as now we have too much steroid, and it can cause things are not going to respond the way that they should. Okay, because we have artificially inflated the amount of steroid in the body or cortisol. Okay, also, we don't want to abruptly pull our person off of that steroid because we don't want to have a sudden drop in the level of cortisol because the body will interpret that as a medical emergency, and we would likely see decreased blood pressure, hypoglycemia, and the body would go into crisis. Okay, so there's a lot of things we got to think about related to the endocrine system for our people who are on long-term steroids. Okay. All right, hypothalamus and pituitary. These regulate homeostasis, and it's actually usually called the hypothalamic pituitary system or complex. Hypothalamus is tiny. It's beneath the thalamus. Okay, hypo, lower thalamus. That makes sense. Hormones produced and secreted by the hypothalamus act directly on other endocrine glands, including pituitary. Okay. In your book, there's a table 40.1, that kind of shows the cascade of everything, how the hormones all interact with each other. The pituitary gland is composed of two lobes. We have the anterior and posterior, and they do different things. Okay. The hypothalamus regulates the anterior pituitary. Um, and then hormones from the posterior pituitary, ADH and oxytocin, which we've talked about before, are synthesized in the hypothalamus, but stored and released from the posterior pituitary. Okay, so you can see how all these glands kind of work together, right? So antidiuretic hormone, ADH, secreted in response to a decrease in blood pressure, dehydration, increased serum osmolality. If you remember from semester 6, we talk about ADH related to all of our renal stuff, right? And we talk about renal in semester 7 too. So all of these things you've heard before, like the RAS, right? Renin, angiotensin, aldosterone system, okay? And then antidiuretic hormone came up with SIADH, syndrome of inappropriate antidiuretic hormone, soaked inside, if you remember that. So the antidiuretic hormone works by increasing water reabsorption in the kidneys. Okay, so because antidiuretic diuretics make us pee, so ADH or vasopressin is going to keep us from peeing. Okay, so just think through what the name of some of these hormones are, because it sounds complicated, but it's really not. Here, slide 7, picture of where the pituitary and hypothalamus are located. Nice little diagram here. All right, the adrenal glands. This is slide 8. So the adrenal glands sit like hats on top of the kidneys. Okay, the kidneys, both kidneys have this little hats on top. Those are the adrenal glands. Okay. They do have an inner core, a middle, and a thick outer covering. And the crazy part is, though, like all of that has different endocrine functions. So even though these guys are tiny, they do different things, which is so kind of crazy. So the medulla is actually under the control of the sympathetic nervous system. Catecholamines like epi and norepi, levo, are secreted from the adrenal medulla when stimulated by the SNS, and their actions vary according to the receptor sites. So two major types of receptors, we have alpha 1s and alpha 2s, and then we have beta 1s, beta 2s, and beta 3s, okay? So the alphas are further differentiated into those betas, okay? Alpha 1 receptors primarily affect response in the vascular smooth muscle, whereas the alpha 2s can decrease release of norepi and influence blood pressure. Beta 1 receptors are located primarily in the heart, and beta 2 in the bronchioles. I remember being in school and remember like learning beta 1, there's one heart, and beta 2, there's two lungs. So I totally remember learning this. Also, you can have beta 2s in the kidneys, but again, we have two kidneys, right? Beta 3s are in the adipose tissue, so in the fat, and when they're stimulated, they enhance thermogenesis, so heat production. So that's, it's just, the whole thing's kind of interesting. Target tissues for catecholamines include various types of cells and organs. And again, you can look at table 40.2 for all the different hormone cascade. Because epi and norepi are also produced by the SNS, the adrenal medulla, and its secretions of these hormones are not necessarily essential to life. Okay, basically because we have a secondary source. That's the big part right there. The adrenal cortex comprises approximately 90% of the adrenal gland and secretes 3 hormones. So there's mineral corticoids, okay, which control fluid balance and affect the kidneys. The target cells of the mineral corticoids are the collecting ducts in the kidney, and stimulation leads to reabsorption of sodium and water. So guess what this is? Aldosterone. Excuse me. Remember learning about aldosterone? Aldosterone likes to hold on to salt and water and help release potassium. And so there are some diuretics, remember, potassium sparing diuretics, that block aldosterone. Because if we block aldosterone, the body is going to release sodium and water. Okay, remember all that? So now we're getting to learn about all those things, kind of in like their hometown, right? As endocrine glands and endocrine hormones. So the adrenal cortex also secretes glucocorticoids. There we go. Glucocorticoids, which are hormones whose effects are essential for life. So these hormones have an effect on carbs, protein, and fat metabolism. They suppress inflammatory and immune functions. Similar to the mineral corticoids, glucocorticoids cause reabsorption of sodium and excretion of potassium. So they function a little bit like aldosterone. And then cortisol, Okay, our steroid is our primary glucocorticoid. So that's easy. That's easy to remember. Slide number 9 is just a picture of the adrenals sitting like tiny little party hats on top of the kidneys. Super cute, very fun. Slide number 10 is a side cut of the adrenals. So you can see the medulla, the cortex, etc. And there it is, still sitting on top of the kidneys. Slide number 11 is table 40.2, straight out of the book. This talks about the catecholamines, the beta 2s, beta 1s, alphas, etc., and what target tissue they have and what the effect is. Okay, so that's straight out of your book. All right, slide number 12 is the thyroid gland. So the thyroid is located in the anterior neck, lies directly below the cricoid cartilage, okay? Thyroid gland produces 3 thyroid hormones. We have T3, T4, and calcitonin. So productions of these hormones requires adequate dietary intake of protein and iodine. One of the interesting things, you know how everybody is using like pink salt and all of that? Good old fashioned salt they added iodine to salt. They iodinized it. Iodinized it? I'm positive that's the wrong word. But they added iodine to it back in the day, way a long time ago. And so people were getting an adequate amount of iodine. Well, now everybody's using fancy pink salt and crystal salt or whatever kind of salt, and it's not iodinized. Again, probably a wrong word. And so now, again, we are seeing low levels of iodine in people because they're no longer receiving supplemented intake of iodine. So kind of interesting there. Because we have not had problems with low iodine in the US in a long time. So release of T3 and T4 is controlled by the hypothalamic pituitary system. It's based on the circulating levels of the thyroid hormones. So T3, T4, and the calcitonin. Okay. So let's see. Sorry. When T3 and T4 levels are low, the hypothalamus is going to secrete the TRH, which stimulates the release of TSH from the anterior pituitary. In turn, TSH acts on the thyroid gland, leading to secretion of T3 and T4. While the circulating levels of T3 and T4 increase, the feedback system causes the hypothalamus to decrease release of TRH. So in turn, it's saying, okay, we have enough of this now. You no longer have to secrete that. We're good, right? So it's that continuous negative feedback system. Let's see, other conditions that increase secretion of TRH independent of circulating T3 and T4 are cold and stress. Okay. End result is an increase in metabolic activity with both conditions. Regulation of metabolic activity is controlled by T3 and T4, and secretion of both hormones increase metabolism. Specific actions of T3 and T4 include increased rate and contractility of the heart, increased rate and depth of respirations, increased O2 use, increased glucose intake by cells, increased glycolysis and enhanced glucogenesis, and increased protein synthesis and catabolism, increased mobilization of fatty acids, increased oxidation of free fatty acids, decreased cholesterol, and phospholipids. Overall increase in metabolic activity results in increased heat production in all tissues. So clinical manifestations of a thyroid disorder are directly associated with those physiological changes. Thyrocalcitonin or calcitonin has a role in the regulation of calcium along with parathyroid hormone. Um, let's see, blah, blah, blah. Okay, this is talking about the relationship between calcium and phosphorus. You know, when we talk about electrolytes like back in six. And then with the kidney stuff, if you remember, we talked about a diet low in phosphorus. And the reason we want our people to have a diet low in phosphorus is because when we get too much phosphorus in the body balances that calcium or balances that phosphorus out by releasing calcium from the bones. So phosphorus and calcium exist in an inverse relationship to each other. So if I have high phosphorus, I'm going to have low calcium. So what the body does to try to counteract the high phosphorus is release calcium from the bones to kind of drive that phosphorus back into homeostasis. But the problem is if I have free floating calcium, I can end up with kidney stones. Kidney stones are primarily made out of calcium. You can end up with obstructions in the bloodstream. You know, we don't want big old fat calcium just floating around, right? So we worry about regulation of phosphorus and calcium um, because of that relationship and the negative impact it can have, particularly on the kidneys related to increased calcium. Slide 13 is a picture of the cricoid cartilage. So you can see the thyroid where it is in relationship to the trachea and the cartilage. Okay. So all right, so slide 14 is the parathyroid glands. If you remember back from semester 6, we learned that the parathyroid is in charge of regulating calcium in the body. So if we have hyper or hypoparathyroidism, that is going to directly affect the calcium in the body. Okay, these are usually kind of embedded in the thyroid gland, but you can kind of feel them above the hyoid bone sometimes. So the parathyroid secrete parathyroid hormone. This is secreted in response to low serum calcium levels. So the target tissues of the PTH include bones, kidneys, and small intestine. So parathyroid hormone increases serum calcium through the following. So it's going to increase bone resorption through osteoclastic activity. It's going to stimulate renal absorption of calcium, stimulate activation of vitamin D, which is going to increase intestinal reabsorption of calcium. So the action of PTH is opposite that of calcitonin. Okay, calcitonin is secreted by the thyroid because calcitonin is going to decrease serum calcium levels, right? Whereas the parathyroid hormone is going to increase those calcium levels. So parathyroid hormone is also going to affect phosphorus levels because it's going to reduce the reabsorption of phosphate from the proximal tubules in the kidneys, leading to a decrease in serum phosphorus levels. It's going to increase bone resorption, leading to an increase in phosphorus release from the bone, increase small intestine absorption of phosphate. And the net result of all of this is to lower serum phosphate levels, particularly due to phosphorus loss through the kidneys. And keep in mind, phosphorus and calcium have an inverse relationship to each other. And the parathyroid is what works to keep that relationship in homeostasis. So one of the things that the body does, if you remember back to when we talked about like renal dysfunction, and we want our people to have a low phosphorus diet, that really doesn't have a whole lot to do with the phosphorus itself. It has to do with the fact that if the body thinks that we have an elevated phosphorus, to get that back into homeostasis, it balances that high phosphorus by releasing calcium. And if you remember, like kidney stones are primarily made out of calcium. Also, calcium is a big old fat molecule, right? And so we don't want extra calcium floating around the bloodstream, especially when we can't flush it, because it can cause obstructions. So it can cause kidney stones, which can cause obstructions, and it's its own set of problems. And then, of course, if it's floating around the bloodstream, it can cause obstruction. So the parathyroid is in charge of keeping that phosphorus and that calcium in balance. Okay. Slide 15, just a nice picture of the thyroid, parathyroid in relation to the trachea and the larynx. Okay, so you can see that. Gonads, slide 16, gonads. These, the gonads are in charge of like sexual development, right? Honestly, you are going to learn more about these in semester 8. Just know that the gonads are part of the endocrine system. They do secrete hormones from the ovaries and the testes. These are like the tropic hormones that are released from the anterior pituitary gland, which is based on secretion of the gonadotropin releasing hormones from the hypothalamus, and then you have like follicle stimulating hormones, FSH, and luteinizing hormones. Those have to do with the egg release and all of that. Okay, so you guys are going to learn about this more in semester 8 for sure. I'm looking through here. Basically, these hormones, for women are about maintaining a normal pregnancy, having normal menstrual cycles, that sort of thing. And then for the guys, it's about production of sperm, and making sure that, progesterone, estrogen in the women, and then testosterone in men and women are both functioning normally. Okay. Slide 17. This is just a diagram of homeostasis versus the stimulus, like what stimulates what. If this is too high or if this is too low, how does this cascade work? Okay, so it's kind of a cool diagram. That's slide 17. It's also straight out of the book. Slide 18 is the pancreas. The pancreas is kind of fun. It's got exocrine and endocrine function. Which is kind of different. The islets of Langerhans, okay, those are our exocrine or our endocrine. Sorry, now I'm just going to mess us all up, right? No, we're talking endocrine. So it's the islet of Langerhans are endocrine, okay? Blood glucose is actually controlled by the islet cells in the pancreas. Two hormones that are released by the pancreas, insulin, right? And glucagon. Okay, so insulin is released from the beta cells, the glucagon is released from the alpha cells. And this is really important related to diabetes because this is what is determining that blood glucose control. So glucose arrives in the bloodstream from either carbs, glucose released from stored glycogen, or glucose newly created, which is gluconeogenesis, and that happens in the liver. Okay, so once in the bloodstream, the glucose is transported to the target cells, and there, insulin facilitates transport of glucose across the cell membrane to the cell's interior. Inside the cell, glucose is metabolized as fuel, releasing energy necessary for normal cell functioning. Without the effective action of insulin, very little glucose would be able to reach the inside of the cell. So instead, glucose would just kind of remain in the bloodstream and blood glucose levels would rise. So that is what we see with diabetes, right? because you either don't have enough insulin, or with like type 1, the pancreas is not making insulin. So we do an A1C, which is a 3-month look at the glucose level of the blood. And we also do finger sticks, and we're just checking the glucose level in the blood, right? So that is inadvertently telling us how the pancreas, the islet of Langerhans cells, are doing releasing insulin, and that whole negative feedback loop. Okay. So a continuous dynamic balance is maintained between the glucose level in the blood, levels of insulin and glucagon, and cellular uptake of glucose. If blood glucose levels are high, more insulin is secreted by the pancreas. Blood glucose is then driven into the cells and metabolized, and as a result, glucose levels in the blood fall. So basically, that's just saying it takes the extra glucose, right, and pushes it into the cells where it can be utilized, and it gets it out of the blood. So then, on the other hand, if blood glucose levels fall too low, so like hypoglycemia, insulin release is suppressed. Okay, so the body's like, oh, we need to not make as much insulin because we already have too low of glucose. So then glucose is going to remain in the bloodstream instead of being driven into the cells. It's going to be allowed to hang out in the blood. In addition, in response to low blood glucose levels, the hormone glucagon is released from the pancreatic alpha cells. So glucagon stimulates production and release of glucose from glycogen stores. So basically, we've got two things going on here. We've got the body saying, nope, I'm not going to release insulin. I want to keep the blood in the blood, keep the sugar in the bloodstream where it's at. Also, because I recognize that that is low, I am going to stimulate the release of extra sugars. Okay, glucagon stimulates the release of glucose, extra sugars from like the liver, which is going to increase those blood glucose levels further. Okay, so that is the body's response to hypoglycemia. All right. Slide 19 is just another little diagram of where everything is located. All right, so nursing considerations and assessments. This is what we really care about, right? Because the endocrine system affects homeostasis and metabolic activity, the nurse must assess changes in nutritional status, physical appearance, weight, sleep patterns, energy, elimination patterns, and reproductive functioning. Evaluating family history for endocrine disorders is also important because some diseases are genetic. So we're going to do our head to toe, obviously. Now, with endocrine disorders, you can have changes in physical appearance, because one of the endocrine hormones is growth hormone, right? So if you have an excess of growth hormone, you get those signs and symptoms of acromegaly, where the people get like a big old forehead and jaw, a large nose, kind of giant hands, giant feet you'll see, where, and also, similarly, if they have, like, maybe they have increased levels of cortisol, so whether that's stress related, or whatever the dysfunction may be, when you have increased levels of cortisol, you get a really puffy looking face. Okay. And that is just in response to that excess cortisol. If we auscultate the chest, sometimes some disorders, some endocrine disorders can have CV implications, maybe tachydysrhythmias related to this. There may be increased vascularity with hyperthyroidism. So we do listen over those carotid arteries, where basically we're listening for bruits, okay, to just kind of see what's going on. You can listen over the thyroid gland. There may be a thyroid bruit related to hyperthyroidism, and that's related to the increase in thyroid vascularity. So there's more whooshing past. That's why we're getting that whoosh sound. Okay. When you go to the doctor, they may palpate the testes, just evaluating shape, size, appropriate for age. If you are talking, younger boys as they're coming into maturity, sometimes if there's a hormone disorder, the testes may not be forming or growing appropriately for age, right? So they think about that. So to assess the thyroid gland, you do want to know this. So to assess the thyroid gland, it's best by being palpated, standing behind the patient. You put the thumbs of both hands on the back of the neck, and the fingers are curved to the front of the neck on either side like this. I think I did it backwards earlier, but there you go. On either side of the trachea. And then you ask the patient to swallow. So you can locate the isthmus by feeling it rise when the patient swallows. And then the nurse assesses both the right and left lobes of the thyroid gland. Right lobe is palpated while the patient's head is turned to the right. And then the nurse assesses for any irregularities or like nodules, right? And then the left lobe is when the patient's head is turned to the left. Okay. You can assess the thyroid gland from the front. With this approach, the nurse faces the patient and uses the thumbs or fingers to palpate each lobe of the thyroid gland. So you would use your thumbs basically like that. Okay. Here's a picture. This is slide 21. This shows palpating the thyroid gland, posterior approach and all of that. All right, so take a look at that slide. Diagnostics. So, we're going to be trying to figure out what's going on, right? Obviously. So, urine and blood, we may use imaging. We're going to look at hormone levels, obviously. There are stimulation and suppression tests that can be done for endocrine diseases. With stimulation testing, this is like aimed at a selected hormone. So they'll give you a hormone which is, remember, this is a cascade. So I give you a hormone, and in response, I expect your body to release another hormone. So it's looking to see whether or not the given hormone stimulates release, right? So that's a stimulation response. With suppression, we try to stop the body from circulating hormones. So this is indicated when we think there are excess levels of circulating hormone. And so when levels of circulating hormone do not decrease with suppression testing, we confirm hyperfunction. Okay, because remember, this is all about hypo and hyperfunction. That is is it making too much hormone or is it making too little hormone? Diagnostics are imaging is just good to look at sizes of things. Because again, if this is like growth hormone or, you know, there's lots of reasons you could have an increase in the size of the gland. It can be cancers, it can be, any sort of stuff. So obviously, imaging is going to be helpful. We also use nuke med studies with diagnosis and evaluation. This is good for like thyroiditis, goiter, right? Goiter is directly related to iodine. And we can look at thyroid nodules, even benign or cancerous. You can use what they do is administer radioactive iodine or an IV injection, and then you look to see where that iodine is taken up. Okay, so with increased uptake, that indicates hyperfunctioning of the thyroid, and you'll see like hot spots. With decreased uptake, that indicates thyroid gland hypofunction. And basically, you'll see what they call cold spots, which means we should have been able to see uptake and we didn't. Okay. So, nursing implications. So, one of the things, I mean, don't forget, even though we're not really talking about the reproductive and hormone glands, don't forget that still when we're talking assessment, that is one of the things we would think about. So for women, it would be like, when is your last menstrual cycle? Um, we would also want to ensure that the patient understands the procedure, obviously, and what radionuclide is being administered. Also, because we're using radionuclides, it's important to ask about menstrual cycle because we want to make sure our female patient is not pregnant, right? The procedure itself only takes about 30 to 60 minutes. You do take all your jewelry, all that sort of thing. And then of course we're going to do baseline vitals and neurostatus beforehand. Sorry, that kind of ended abruptly. Our last slide here is age-related changes. You know, we always want to think about age-related changes. Endocrine function is no different than everything else. It becomes hypoactive as we get older, okay? Um, and the thing is, this can be related to increased incidence of chronic disease. It can play into that. We also have menopause. You know, women lose all their hormones. Plus, there's decreased metabolism. Uh, and as usual, we want to do, though, a comprehensive evaluation to rule out other causes. We don't just want to assume that it's age related because there could be a tumor or something going on. So just keep that in mind. Although we are expecting um, endocrine function to become hypoactive, we still want to make sure it really is just age related. Okay, that concludes PowerPoint number 1. Thank you guys.